A tablespoon of extra virgin olive oil produces a slight burning sensation at the back of the throat, sharp enough that people unfamiliar with a high-quality bottle sometimes mistake it for spoiled oil. That sting has a name: oleocanthal. It is the same compound responsible for one of the more unexpected findings in nutrition research over the past 2 decades, that this particular fat inhibits the same enzymes ibuprofen inhibits, cyclooxygenase 1 and cyclooxygenase 2, the pair responsible for producing the prostaglandins that drive pain and swelling in an inflamed joint. Researchers who first noticed the throat sensation resembled the one produced by liquid ibuprofen went looking for a chemical reason and found one. A 50 milliliter daily serving of high oleocanthal olive oil delivers a dose roughly equivalent to 10% of a standard adult ibuprofen tablet, working through the identical pathway, just far more slowly and far more gently on the stomach lining. This matters more after 50 than before it, because the inflammatory load most bodies carry rises with age independent of diagnosis. Cartilage that repaired itself overnight at 25 takes longer at 55. Low-grade systemic inflammation, the kind that does not show up as a specific disease, but shows up as stiffness getting out of a chair, becomes a background condition rather than an occasional annoyance. None of the 5 foods here reverses that process the way a prescription anti-inflammatory does in a single dose. What the research supports is something slower and cumulative, closer to lowering a baseline than eliminating a symptom. Fatty fish sits at the center of the omega-3 research for a reason that has nothing to do with trend and everything to do with how consistently it replicates. Salmon, sardines, mackerel, and similar cold water fish carry EPA and DHA directly, the long-chain omega-3 fats the body uses to build a class of signaling molecules called resolvins, compounds whose entire job is to end an inflammatory response once it has done its work, rather than let it linger. A body low in EPA and DHA produces fewer resolvins, and inflammation that should resolve in days instead drags on. 2 servings a week is the dose most commonly used in the research showing joint benefit, not a daily requirement, which makes this one of the more achievable changes on this list for someone who does not particularly enjoy fish. Tart cherries, specifically the Montmorency variety, used in most of the clinical trials, carry a concentration of anthocyanins, the deep red pigment compounds, high enough that a clinical trial testing them against knee osteoarthritis found measurable reductions in both pain and inflammatory markers over the trial period. A separate randomized crossover study used a proprietary cherry juice blend and found similar results in knee osteoarthritis patients specifically. What makes cherries an interesting addition to this list is that the research on them started somewhere unrelated entirely, in sports medicine, where athletes drinking tart cherry juice after intense exercise showed less post-exercise muscle inflammation than those who did not. That finding opened the door to testing the same juice against chronic joint conditions, and the results held up. Walnuts contribute a version of the same omega-3 pathway as fatty fish, through alpha-linolenic acid rather than EPA and DHA directly, alongside a set of polyphenols concentrated mostly in the thin papery skin most people peel off and throw away, without realizing it holds a meaningful share of the nut's antioxidant content. The ALA conversion rate to the more active EPA and DHA forms is inefficient, the same limitation relevant to any plant-based omega-3 source, but walnuts are rarely eaten for ALA alone. The combination of fat profile and polyphenol content together is what shows up in population studies linking regular walnut consumption to lower inflammatory markers, not either compound in isolation. Ginger's case is the most directly comparable to a pharmaceutical of anything on this list. Gingerol, the compound responsible for ginger's characteristic bite, was tested in a randomized controlled trial using a standardized 2-gram daily extract against knee osteoarthritis pain, and at 12 weeks the effect size was comparable to 400 milligrams of ibuprofen. This does not mean ginger extract and ibuprofen are interchangeable across every situation. Ibuprofen acts faster, and its dosing is far more standardized across brands and preparations than a ginger supplement typically is. But for someone managing chronic joint pain who wants to reduce reliance on daily over-the-counter medication, a result that size, from a root that has been used medicinally for thousands of years before anyone isolated gingerol from it, is worth taking seriously rather than dismissing as folk remedy. It helps to understand what inflammation actually is before deciding which foods address it, because the word gets used loosely enough in nutrition marketing that its actual meaning tends to blur. Acute inflammation, the swelling around a sprained ankle or a cut finger, is the immune system doing exactly what it should, mobilizing resources to a site of damage and then standing down once repair is complete. Chronic low-grade inflammation is different. It is the same immune machinery left partially activated for months or years, often without an obvious trigger, quietly damaging tissue it was never meant to attack continuously. Joint cartilage, which has poor blood supply and limited capacity for self-repair to begin with, is particularly vulnerable to this kind of slow, background wear. The 5 foods here are not treating an injury. They are addressing the chronic, low-grade version, which is why the timeline for seeing results looks nothing like treating a sprain. Blood tests exist for tracking this more precisely than a person's subjective sense of their own joints. C-reactive protein, usually shortened to CRP, is the marker most commonly used in the research cited here, a general indicator of systemic inflammation that rises and falls with dietary and lifestyle changes over a period of weeks to months. Someone genuinely committed to testing whether these foods are doing anything measurable, rather than guessing from how their knees feel on a given morning, can ask a doctor for a baseline CRP test before making changes and a follow-up test after roughly 2 to 3 months of consistent dietary change. This is not necessary to benefit from the foods themselves, but it turns an anecdotal impression into an actual data point, and it removes the guesswork that makes so many people abandon a dietary change before it has had time to register. None of these 5 foods works instantly, and the research behind each of them measures results over weeks, not hours. The tart cherry and ginger trials ran roughly 12 weeks. The olive oil research on rheumatoid arthritis patients tracked disease activity scores over a period long enough to account for the slow, cumulative nature of dietary intervention rather than a single dose response. A person trying one of these foods for a week and expecting a noticeable change in joint stiffness is applying a pharmaceutical timeline to a dietary one, and the mismatch is where most people give up before the effect has had time to appear. There is also a question of stacking that the individual studies, each testing one food in isolation, cannot fully answer. Real diets do not isolate variables. Someone eating fatty fish twice a week, cooking primarily with high oleocanthal olive oil, keeping walnuts as a regular snack, and adding ginger to meals is combining several anti-inflammatory pathways simultaneously. Resolvin production, COX inhibition, ALA and polyphenol intake, and gingerol's separate mechanism, and no clinical trial has cleanly isolated what that combination produces versus any single food alone. The population-level data from Mediterranean and similar dietary patterns suggest the combination outperforms any single component, but that is an inference from population studies, not a controlled trial result, and it is worth being honest about the difference. Sourcing matters more for some of these 5 than others, and it is worth being specific rather than vague about it. Not all olive oil sold as extra virgin actually carries meaningful oleocanthal content, since the compound degrades with age, heat exposure, and poor storage, and a significant share of commercially available bottles are diluted, mislabeled, or simply old by the time they reach a shelf. The throat sting itself is a rough but genuinely useful test. An oil with little or no peppery bite likely has little oleocanthal left in it, regardless of what the label claims. Tart cherry benefits are specific to the Montmorency variety and similar tart cultivars used in the actual trials, not sweet cherries, which carry a different and less concentrated anthocyanin profile. Ginger's dosing in the 12-week trial used a standardized extract rather than an arbitrary amount of fresh root, which matters for anyone trying to approximate the studied dose rather than simply adding ginger to cooking occasionally and hoping the amount is comparable. Walnuts and fatty fish are more forgiving on this front. A standard serving of walnuts, roughly a small handful, and 2 weekly servings of salmon, sardines, or mackerel align closely enough with what the population studies actually measured that precision matters less than consistency. This unevenness across the 5 foods, some requiring careful sourcing and dosing, others working at whatever ordinary serving size a person would naturally eat, is not something the marketing around any single superfood tends to mention, because uneven, food-specific caveats do not fit neatly into an 11-word headline. A man in his late 50s managing early knee osteoarthritis started making these changes gradually rather than all at once, switching his cooking oil first, then adding salmon twice a week, then working in a small daily dose of fresh ginger grated into tea. He did not stop his prescribed anti-inflammatory medication, and nothing here should be read as an argument to do that without a doctor's involvement. What he described after roughly 2 months was not the absence of pain but a longer stretch between flare-ups, and a milder version of the flare-ups that did happen. That is a modest, unglamorous result, and it is also roughly what the underlying research would predict, rather than the dramatic reversal implied by more aggressive marketing around any single ingredient on this list. The caveats worth naming directly involve blood-thinning medication and surgery timing. Fish oil at high doses, tart cherry compounds, and ginger all carry mild blood-thinning properties independently, and someone on prescribed anticoagulants or preparing for a scheduled surgery should mention all of these foods to whoever manages that care, the same way they would mention a supplement. This is not a reason to avoid any of them under normal circumstances. It is a reason to say the words out loud at the next appointment, rather than assume a food is automatically exempt from the conversation a medication would require. What ties fatty fish, olive oil, tart cherries, walnuts, and ginger together is not a shared flavor profile or a shared culinary tradition. It is that each one arrived at its anti-inflammatory reputation through a different research pathway entirely. Sports medicine for cherries, rheumatology for olive oil, cardiology for fish, and traditional medicine re-examined by modern pharmacology for ginger, and all five converged on variations of the same conclusion. Inflammation that builds slowly over decades responds, modestly and gradually, to interventions that work the same way.